Hello, this is David Bishai, and I'm here to present part 3 of our lecture on health insurance and healthcare costs in America. This part is entitled Medicaid, and we're going to be talking about the Medicaid program in America. Medicaid was started in 1965, the same year as Medicare. It's really 50 separate state insurance plans because the states get a lot of control in some of the design elements of the Medicaid plan. Not full control. The federal government still insists that all plans have to cover low-income people of all ages, especially offering nursing home benefits to low-income seniors, or low-income anybody who needs nursing home, but that's typically seniors. The federal government will share the costs of a state's Medicaid program as long as they meet federal regulations and guidelines. And the federal government will match dollar for dollar Medicaid spending that conforms to the federal guidelines. So Medicaid guarantees coverage under people who meet federal and state eligibility criteria, and the federal government will match state money. Guaranteed coverage for people who qualify, and the dollars are coming from state budgets, from state tax revenue, but also from the federal tax revenue, so it's a way for the federal government to send money out to the states. It doesn't send the same amount of money out to the states. If states have very, very low-cost Medicaid programs, they're not going to get as much federal money. And so some states benefit more from Medicaid. The more generous a state is in Medicaid money, the more federal money it's going to get, but the more of its own state money it has to use up in order to qualify for the matching. Now, the eligibility criteria for Medicaid, as I said, it covers low-income poor people, and that turns out to be about 1 out of every 7 adults having low enough income to qualify for Medicaid. Children are poorer than most average Americans, and so 2 out of 5 American children qualifies to be covered by Medicaid. Seniors are somewhat poor, and 1 out of every 5 seniors, Medicare beneficiaries, qualifies for Medicaid too. This group here, the Medicare beneficiaries who also qualify for Medicaid, they are called dual eligibles, and they're considered separate because they qualify for both Medicare and Medicaid. 3 in 5 nursing home residents in America are being covered by Medicaid. So if you are in the nursing home industry, Medicaid is an enormous part of how you plan to run your business. Disabled people do qualify for Medicaid, and 2 out of every 5 Americans with disabilities is covered by Medicaid. Even though all of these groups are in the pool, the numbers don't always match up. So if we look at who the pool is, 76% of the eligibles for Medicaid are children and adults, typically with low income and disabilities. So 76% of people who qualify for Medicaid are children and adults, and 24% are seniors and disabled. So most of the people who ought to be on Medicaid are low-income people, and the minority are the seniors and the people with disabilities. But when you look at the dollars spent, being a senior or a disabled person is much more expensive. And so the money goes 64% to the seniors and disabled and 36% to the low-income children and adults. That's just a matter of how expensive it is to be a senior or in a nursing home or to be a disabled person. Seniors and people with disabilities cost a lot more, as I was saying. If you're a person with a disability, you're going to cost about $16,643 a year. If you're a senior in a nursing home, you're going to cost about $13,249 per year. But if you're an average low-income child or adult, your annual Medicaid spending in 2011 was much less, at $2,400 for children and $3,200 for adults. The long-term care expenses are really what's driving a lot of these gray bars. If you look at the long-term care component of the disabled expenses, you're going to be seeing that more than half of that $16,643 is for long-term care in nursing homes, and for seniors, about 1/4 of that $13,000 is for long-term care. Now, as I was saying, the generosity of Medicaid programs varies across the states. These are 50 different state programs, and each state legislature gets to decide how generous to be, how many people to cover, and what income threshold qualifies you as a low-income person in that state. And that's how you set your coverage level. Some states are not so generous, and they're shown here in white, that only spending $4,000 to $5,650 per person. They just don't have great coverage. These darker blue states are more generous with their Medicaid spending from between $8,000 and $11,000 per person. So Medicaid has also faced this rising cost problem, and it's facing that rising cost problem in an environment where political support for Medicaid from seniors who are disabled and low income and in nursing homes, as well as low income adults and children, they're not often given a lot of political power in most states. And so there's this race to the bottom in some states where compensation is pushed down to marginal cost. Let us have the fee schedule for Medicaid as low as it can possibly be and still have a program. And as a result, the Medicaid fee schedule, which is public, shows that they are paying the lowest possible cost they can get away with. The cost is so low that many providers say, I will not see a Medicaid patient, and it's a free country. So far, the states cannot compel you to see a Medicaid patient. Nursing homes can also say, we won't see a Medicaid patient. And if you see only Medicaid patients, you have a long waiting list, and you can easily fill your nursing home with Medicaid patients. So we've got nursing homes that are often devoted to only Medicaid patients, and they don't compete on quality because they know they can fill their beds at that Medicaid fee schedule. Many state programs will offer Medicaid managed care. And in a managed care package, a vendor goes to the state and says, we will take capitated patients from you. We will sign up and we will just take $3,000 for every low-income Medicaid person you give us. They want to do the least possible and get away with it among a group that lacks a lot of political voice. And so things can go wrong with the quality of care, under managed care, and state health departments and state public health officers now find it's their job to make sure that in a state-managed Medicaid program, quality standards are met. One has to be really looking over the shoulder in these Medicaid programs to prevent the race to the bottom from hurting people, from the state Medicaid vendor taking the capitated payments and doing a lousy job taking care of sick people. If you're harmed as a result of skimping on your medical coverage, you have to sue the hospital and the doctor. You can't sue Medicaid. So the vendor who takes the Medicaid program and skimps on coverage is indemnified and cannot be sued. We've been talking about managed care a lot in our discussions of Medicaid and Medicare. In the next part of the lecture, we're going to talk about managed care itself and really dig in deep on what that is. So I'll see you back in that lecture.